vanishing and then the tolerance start developing, then we will discontinue calcitonin. We will see the dose of bisphosphonates in the subsequent slide. As you can see here, there are several bisphosphonates available: zoledronic acid, pamindronate, etondronate. Of the three, zoledronic acid is preferable because its duration of action is longer and it is a single dose administration. It is available as Zometa from Novartis, 4 milligrams ampule, 4 milligrams vial. It has to be diluted in 100 ml of normal saline and to be infused intravenous over a period of at least 15 minutes once in a month, because the duration of action of zoledronic acid is roughly around 4 weeks or 1 month. So if the hypercalcemia persists, we may need to repeat zoledronic acid or Zometa after 1 month. Particularly hypercalcemia of malignancy will respond, but again the recurrence will occur, the hypercalcemia will shoot up, then again a second dose of zoledronic acid will be required after 1 month. Pamindronate or Pamidria is also available, 60 milligrams IV infusion over 4-hour intervals, repeated after a month. And etidronate is available as 7.5 milligrams per kilogram IV over 4 hours. It is given as IV infusion daily for 3 to 7 days. The problem with this drug is we have to give it over a period of 3 to 7 days, and this is diluted in 250 ml of normal saline and infused. Duration of action is around 2 to 3 weeks. The problem is this is not a single dose, we have to give for 3 to 7 days. So the choice of treatment with bisphosphonates will obviously be Zometa or zoledronic acid as a single IV dose of 4 milligrams given over a period of 15 minutes, diluted in normal saline. If necessary, the hypercalcemia recurs to be repeated after 1 month. How do these bisphosphonates act? The main mechanism of action of bisphosphonates is through inhibition of bone resorption. They inhibit the osteoclastic activity, they inhibit the bone resorption, they will not allow any calcium to enter from the bone into the system in spite of there being PTH or in spite of there being PTH-RP. Either there is an excess PTH or an excess PTH-RP causing the hypercalcemia, and the effect of those two hormones is to resorb the bone. Bisphosphonates go and block the resorption of bone by inhibiting the osteoclastic activity. There are some more miscellaneous forms of treatment which we will see in the next slide. But here please remember, the bisphosphonates alone should not be started because bisphosphonates take little time of 2 to 3 days or 4 days, during which time you try to cover the hypercalcemia using calcitonin and withdraw calcitonin after 3 days, and of course the bisphosphonates will take over from there, and only we need to monitor the calcium levels and if necessary use saline diuresis or glucocorticoids intermittently to control the calcium until 1 month, at which time again bisphosphonates can be repeated. These are some of the other treatment options available for a case of hypercalcemia. In cases of hypercalcemic crisis, one probably need to do a dialysis in refractory cases where saline diuresis, furosemide, calcitonin, bisphosphonates have failed to bring down the calcium to reasonably lower levels to prevent the complications of hypercalcemic crisis. In such a case, low calcium containing fluid is used as a dialysate, and dialysis is done so that the fluid which is having low calcium dialysate will trap the calcium from the blood, and then the calcium is dialysed through the dialyzer. Of course, treatment of underlying parathyroid adenoma using parathyroidectomy, provided the patient satisfies the indications for surgery which we have already listed. Most important thing about hypercalcemia treatment is to treat the underlying cause. The underlying cause is malignancy. We have to take steps to see and control the malignancy. If it is due to drugs like thiazides, you have to stop. Milk alkali, stop the antacids and excess calcium. or vitamin D intoxication, stop the offending drug and things like that. Of course, we have 3 other drugs, miscellaneous drugs here. The plicaomycin available as mithrasin, 25 micrograms per kilogram per day, given as intravenous dose for 4 days. This is an anti-resorptive drug, just like bisphosphonates. It substitutes the action or supplements the action of bisphosphonates. Gallium nitrate available as Ganite, 100 milligrams per meter square per day, given intravenous for 5 days in 1 liter of normal saline or 5% dextrose, slowly. This also is an anti-resorptive drug. It can be tried. The other drug is what is called the cinacalcet or Sensipar, which is similar to the calcitonin, 30 milligrams per oral once a day. It increases the sensitivity of the calcium sensing receptors in the body. So calcium sensing receptors in the body are sensitized and the sensitivity is increased, so they get stimulated and they activate the parathyroid hormone to drive off the calcium from the blood. So these are some of the other treatment options that we see as far as hypercalcemia is concerned. But again, to reiterate, the basic fundamental step is to saline rehydration, dialysis with loop diuretic furosemide, use calcitonin along with bisphosphonates, and then calcitonin dropped after 3 days. Bisphosphonates will take over if necessary. Monitor the calcium every 2-3 days or every day in case it's required. If necessary, give glucocorticoids or reinforce saline rehydration and saline diuresis as and when the calcium levels are slightly going up. Of course, supplemental treatment with plicaomycin, gallium nitrate or cinacalcet can be tried, and treatment of the underlying condition is one of the most important steps to see that the hypercalcemia doesn't recur. And we have one more slide, which is the take home messages. Let's see what is important in that. Dear friends, we have come to the conclusion of the CME and hypercalcemia. These are some of the important take home points. Remember, hypercalcemia is often asymptomatic and needs to be screened. Unless we screen all susceptible patients by doing serum calcium, we will not be able to identify unless it is moderate or severe hypercalcemia. Mild hypercalcemia is usually asymptomatic. If elevated, serum calcium elevator is elevated, do an IPTH and follow the algorithm of our differential diagnosis. Remember once again that 90% of the cases of hypercalcemia are either due to hyperparathyroidism or an underlying malignancy. All the other causes form 10% of the cases. Vitamin D toxicity, particularly supplemental vitamin D patients may be taking during their nutritional supplements along with the vitamin capsules and other things, or doctors giving vitamin D injections or supplemental vitamin D with calcium, particularly the active form of vitamin D calcitriol plus calcium compositions indiscriminately might cause, is an important cause nowadays. Thiazide diuretics are a common and treatable cause. Vitamin A overuse also is a treatable cause. Remember, adequate hydration with N-saline hydration and furosemide diuresis play the key role in bringing down the calcium levels faster. Calcitonin and zoledronic acid are the mainstay of treatment for hypercalcemia. With these few take-home points being reiterated here, I thank you all for your patient listening, and I hope the problem of hypercalcemia has been clarified, and those of you who have any questions can ask me right now, and to the extent possible I will try to clarify the doubts to the satisfaction of you. But those of you who are viewing on the web this particular CME, you can